Hello everybody, we're going to talk today about gastro-esophageal reflux disease, the sleeve gastrectomy, and how to deal with it using the BioA mesh. As you know, GERD exists in up to 50% of bariatric patients, and nowadays worldwide, sleeve gastrectomy is the most commonly performed bariatric operation. And post-sleeve GERD is still an issue. It's even a very expansive issue that is being more and more debated nowadays. So how to deal with the sleeve GERD dilemma? I would like in the upcoming slides share with you my reflections, my tips and tricks. It all started more than 5 years ago when papers from all over the world evoked the exposure of the distal esophagus to severe reflux due to the sleeve gastrectomy. And for example, in this very famous meta-analysis, you should take a look at the risk of PPI use post-operatively and what we call now the intrathoracic migration of the sleeve gastrectomy, which is a pseudo-hiatal hernia. And as you can see, both figures are very similar. So we may think that the sleeve gastrectomy, by creating an intrathoracic migration, may provoke, worsen, or make a GERD reluctant to usual therapy and become a real problem. So in this systematic review in 2022 on the new onset of sleeve gastrectomy, of post-sleeve gastrectomy GERD, the authors concluded that there are nowadays multifactorial relationship between sleeve and GERD, and most recent studies have showed satisfactory control of post-operative reflux in most patients, meaning that the obesity itself was at the origin of GERD, and this negative factor was very positively outbalanced by the effect of sleeve gastrectomy. Many factors explain GERD after sleeve, including the hypotension of the lower esophageal sphincter, the hiatal hernia rate, the gastric sleeve shape, and so. However, no firm convictions enable us today to graduate the importance of such factors. However, we all agree that the rules of a perfect sleeve should be respected in order to lower the risk of GERD. And these rules are very well known worldwide, meaning to use the largest bougie possible to reduce the risk of narrowing, shape the sleeve like a widest antrum to be able to diminish or to decrease as much as possible the hyperpressure generated by the sleeve, prevent the narrowing at the incisura angularis, and place the last staple line close but not too close to the His angle in order to avoid narrowing and leaks. Of course, hiatal hernias should be repaired. Large, what is the definition of large is not yet known, but we admit that 4 centimeter is a good threshold. The sleeve gastrectomy has its own anatomy. It's different from the native gastric anatomy. And in order to understand this anatomy, you should, and I recommend, to do the 3D CAT scan volumetric analysis of the sleeve, which we call in France the gastroscan, which is a special test that enables you to inflate the stomach as much as possible using oral medications that will constrict the pylorus and inflate at the same time the stomach. This will help you evaluate real life 3D volume of the stomach in order to disclose any narrowing at the incisura, any hypertrophic fundus, as we can see here, or any narrowing at the esophagogastric junction. And consequently, sometimes we can see a beautiful hiatal hernia or the remnant of a lap band that was transformed to sleeve. For example, take a look here. We can see a very narrowed incisura angularis that was at the origin of a heavy post-sleeve gastrectomy GERD that required eventually Roux-en-Y gastric bypass. So what are the options in the bariatric population when you have GERD in a patient who is obese and who is candidate for surgery? Of course, you may do a Roux-en-Y gastric bypass. This is not in my topic. You may do a sleeve gastrectomy and a fundoplication. I will say a word about this. Or you may repair the hiatus and do a sleeve anyway, or you may do better, and we think that this is better. You repair the hiatus and you reinforce it. Just one word about the fundoplicated sleeve. This is an operation that we do not recommend at all because it has an increased risk of complications, unusual complications, especially necrosis of the upper stomach and complex leaks, which incidence is very high as compared to the normal sleeve. And we have our own experience in the difficulties of this operation. So what about hiatal repair alone and sleeve gastrectomy? I must confess that the results are controversial because opposite conclusions can be drawn from different major papers. Like in this one, you can see that the hernia repair is positive. It favors the control of sleeve and the absence of PPI addiction in the post-operative course. If you go to other very well done meta-analysis also, you can read that there is no differences in GERD between hiatal hernia repair during sleeve as compared to sleeve without repair. You know, the hiatus is a very curious area. It's completely different from other hernias. It looks like, you know, the parastomal hernia, because in normal, let's say, abdominal wall hernia, when you close the hernia, you close it completely. While if you have a stoma or a hiatus, the closure cannot be complete. Otherwise, you will not have room for the esophagus or for the stoma itself. This is why it's very difficult to find a solution that will enable you at the same time to have a good control of the orifice, allow the organ, the hollow viscous coming through it, to go without any constriction, which causes dysphagia, and to enable the pressure from the abdomen to push the liquids and the reflux into the thorax, into the esophagus. Many shapes of the used mesh have been reported. Either you use a U-shape one, which we prefer, or the keyhole, which can sometimes be used by a combination of two U-shaped, or by drawing a hole in a mesh and then doing sutures over it. So let's take a look at this systematic review and meta-analysis of a laparoscopic mesh versus suture repair in hiatus hernia. And as you can see in this very well done meta-analysis, the closure and the repair of the hiatus hernia using the mesh is more favorable as an outcome as compared to not using a mesh. And you can see here that the complications are not significant. Of course, there is less complications when you don't use a mesh, but these complications are very rare and not significant. Dysphagia as well is more present when you have a mesh, but this is not significant, especially if you have experience in closure and the way you put your mesh. The quality of life also favors the use of mesh, as you can see it here, and it is significant. You know that bioabsorbable mesh are to be preferred for many historical reasons and for the fact that this area may be subject to reoperation or complications due to a non-absorbable mesh, and this is the past that led us to this conviction. And our bioabsorbable mesh that we prefer is the Bio-A, as you know. And this is a recent paper which is a review of 21 studies, including almost 900 subjects that had the Bio-A mesh. And the conclusion is very interesting. Hiatal hernia repair with bioabsorbable is more effective in reducing hernia recurrence as compared to simple suture cruroplasty. So this is very interesting. Of course, we need further investigations to understand what happens at the long run. Let me now tell you about our study protocol that led me to have these convictions and these remarks and these conclusions regarding the use of Bio-A for the hiatal hernia control. We started the study protocol more than 6 years ago, applying the usual conditions of how to perform a sleeve gastrectomy in a patient with hiatal hernia. We try not to dissect anteriorly a lot. Of course, if you have a big hiatal hernia, you need to remove the sac and you have to dissect anteriorly. But if the hiatus is large and the hernia is not very significant, you dissect only posteriorly and you do your cruroplasty floppy. Floppy is important, and when I say floppy, is not only tightened as compared to the esophagus, but also not tightened when you reapproximate both crura. Remember, it could work like a seton in an anal fistula. If you tighten it, it will end up by going through the sphincter, and your sutures also can do the same at the hiatus. We use a Bio-A mesh that we never fixate because its fixation may be risky and useless. We just impact it and incarcerate it by holding it by the spleen and the caudate lobe. Unfortunately, I could not insert a video in this presentation for time's sake. So we have now more than 120 cases of sleeve gastrectomy with Bio-A and hiatal repair. These figures you see here are on the first 113 cases. They all achieved and completed 36 months follow-up. The recurrence was less than 5%. Reflux was barely, if ever, present endoscopically, and conversion to Roux-en-Y gastric bypass was very rare, and the complications related to the mesh were inexistent. So, let us conclude together that GERD is a serious complication. It may lead even only theoretically, but this is also practical, to cancer. Non-morbidly obese patients should be preferentially treated medically. And morbidly obese patients with GERD should not be systematically denied sleeve. This is very important because I hear people sometimes saying, oh, he has GERD, no sleeve. This is not true. de novo GERD may exist in up to 1/4 of the patients with the sleeve gastrectomy. Hiatal repair should be done with strict anatomical rules. Reinforcement is better, and if you decide to use a reinforcement option, I recommend BioA for many reasons I exposed in this topic. So endoscopic follow-up is also very, very important for any sleeve gastrectomy patient with or without repair to try to screen and discover GERD as early as possible. This is a rapid algorithm of how I do with my patients when they have hiatal hernia or no hiatal hernia. Sleeve gastrectomy is done in many cases, and sometimes you do Roux-en-Y gastric bypass, and this is for the GERD after sleeve. How do you do it, and how do you recommend to take care of these patients when they have GERD after sleeve, because it's not too late to treat it. We have lots of options, but obviously this is not the object or the subject of our topic. Thank you very much, and hope to see you face to face soon. Goodbye.